Hello, and welcome to the Consortium of Universities for Global Health's webinar series. Today, we have a very important webinar on reducing race-based disparities in the United States. Dr. Regina Davis-Moss, the Executive Director for Public Health Policy and Practice at the American Public Health Association, is going to be our speaker today. Dr. Tom Levesque unfortunately had an emergency and was unable to appear on the webinar right now, and he sends his regrets. We have seen, tragically, COVID-19 shine a bright light on deep social inequities affecting the United States. These race-based inequities have been around for generations. So thankfully, this light has been shone on those challenges. This is an opportunity for all of us to address those issues that have disproportionately affected communities of color. We have seen that African Americans, Latinx, and other minority groups have not only fallen ill disproportionately with COVID-19, but they've also died disproportionately. This is due to a complex mixture of issues. One overlapping area, of course, are the social determinants of health. Access to healthcare, education, housing, and social programs, clean air, and others that are vitally important for all of our abilities to have equal opportunity and to live lives of safety and security and healthy lives. Dr. Davis today is going to address two more important aspects of those areas: housing and healthcare. Housing, and also she's going to talk about education. Housing and education, two areas that unfortunately sit structurally in the United States, where communities of color have been disproportionately negatively affected in those areas. Now I'll talk about healthcare and a few other important areas that are also critically important to addressing outcomes. We have an opportunity, all of us, to be able to address these issues, particularly since this is an election year. So what I'm going to do now is turn it over to Dr. Davis-Moss, and we're very thankful, Dr. Davis-Moss, for you coming on to share your expertise in these areas, and then it'll come back to me. So welcome, Dr. Davis-Moss, and thank you very much for being here.
Thanks, Dr. Martin, and thanks for having me. Today I'm going to talk to you about two of the, if you include them with economic inequality, are arguably two of the major key drivers of health. I'll start by giving a little background, then talk about what we've learned, and then strategies to address these issues and programs that are working. Next slide, please. First, I'll start with housing and health. And I'm going to start with discussing the connection between housing and health inequities. Next slide. Americans spend, on average, 70% of their time in residential environments. And this proportion can be even higher when you're looking at vulnerable populations like the elderly, disabled, or very young, which means our home environments have significant potential to influence our health. The relationship between housing and health is even more, in my mind, I would say, than just the four walls that we live between or the shelter that it provides for us each night. If you look at this slide to the left, you'll see it's an analysis from the Urban Institute, and it reveals that home ownership is a key contributor to the disparity in wealth accumulation by race. So the graph basically demonstrates that over time, little change has occurred in the gap between the rate of home ownership between whites versus African Americans, reported as Blacks, and Latinx, reported as Hispanic. So I hope this makes the case. When I talked about income inequality, this makes the case as to why home ownership is a key factor in establishing wealth, because it represents a pivotal tool for how we create generational wealth. And also it is a contributor to inequities for those who cannot afford home ownership and will ultimately have an impact on their health and well-being. This is an enduring effect because home ownership is a primary source of wealth among Americans, as I previously stated. Next slide, please. So let's now talk about how housing affects health. It affects health in multiple ways, and the ways are the pathways are interrelated. And they include neighborhood context, affordability, ownership, and quality. These can either work together to promote health, or they can work to undermine health and well-being. So let's start with neighborhood context. So this includes those physical attributes of the neighborhood, such as ability to walk, bike, how close it is to traffic, air quality, as Dr. Martin already mentioned, access to public transportation, parks, and access to fruits and vegetables, but also those social and community attributes, such as how cohesive the community is, whether it's there's segregation, whether there's a concentration of poverty. In low income neighborhoods, we frequently see this lack of physical aspects that I talked about. And these are the ones that we need to support good health. So when we see that, we see those increases in significant race-based inequities. So residents of disenfranchised neighborhoods experience limited access to transportation. They rarely have the infrastructure to even support new modes of transportation if that was a desire. There's usually less access to jobs, poor quality schools, higher crime, greater environmental exposures, and limited opportunities to build financial assets. So for example, low-income communities and communities of color have more high-speed, high-traffic roads and poor pedestrian and bicycle infrastructure. They often tend to be situated close to highways as well. With regard to affordability, unaffordable housing affects health by reducing the income that households have available for things like being able to purchase nutritious foods or even to pay their healthcare expenses. But it can also cause stress. There's the not being able to afford housing can cause instability because you're constantly moving around, as well as if you are having to live with a lot of others or living in very densely packed areas, there's crowding. Stress, depression, anxiety, or hopelessness has been clearly documented and associated with unstable or cost-burdened housing. It's also been associated with an array of physical problems like hypertension, heart disease, and crowding has also shown to increase psychological distress, including worsening behavior problems in children, increasing the risk of transformation of infectious diseases, such as TB and things like that. And then unaffordable housing may also hinder the ability of individuals to move to safer conditions, whether that because an individual can't move out because of domestic violence, or they are unable to pay their utility bills, or even to do the general maintenance on their homes. With regard to home ownership, homeowners report that they have better physical and mental health when you compare them to renters. And this association holds true even for homeowners with higher housing cost burdens. So there's something to be said about the home ownership variable. However, homeowners in foreclosures have been shown to experience worse physical and mental health outcomes than renters. This evidence is mixed when it comes to the impact on children, and it's really honestly difficult to assess. With regard to poor housing quality, that has an impact on housing-related illness and injury, including asthma, childhood lead poisoning, lung cancer, secondhand smoke, older adults having increased risk for falls, carbon monoxide poisoning, fire-related injuries, childhood injuries, and other respiratory illnesses. One study said that African Americans and low-income people are 1.5 to 2 times more likely to occupy homes with severe physical problems. It's also worth noting that many of these conditions are exacerbated by a changing climate. So as we continue to see changes in climate, the exposures are likely to increase because we're spending more time indoors, and I offer to you, we're probably going to see more of that as we're spending more time right now indoors with regard to COVID. So as you can see, the current state of housing in this country falls short of meeting the basic needs of many people, and it often impacts them negatively. Next slides, please. So now let's examine how structural racism, both historic and ongoing, and things such as residential segregation, has an impact on housing and health. So if we start with redlining, which is a systematic banking lending practice of denying mortgages and small business loans to Black, Brown, and Indigenous neighborhoods, and has been happening for over the past century, it has a tremendous impact on health. It's now deemed illegal by the Fair Housing Act of 1968, but it still has lingering ramifications, as these historically redlined neighborhoods are still significantly more likely to house people that are low income and people of color. These redline communities are also less likely to have access to job opportunities and basic services such as banking, healthcare, and transportation. With regard to exclusionary zoning, which is the practice of applying local zoning ordinances such as a minimum lot size, minimum square footage, costly building codes, all to prevent affordable multi-unit houses from being developed, has an impact because these policies basically keep poor residents out of specific neighborhoods. They also drive up housing costs and keep these certain families from, even if they, in their best efforts, having access. Now, unlike redlining, which is now illegal, exclusionary zoning is still legal. Restrictive covenants. So this is another zoning requirement that is illegal, but it's still a hurdle because it's ongoing in terms of the ramifications. But basically, it used to be that in property deeds for existing housing or undeveloped lots, there were legal and binding obligations that a seller must adhere to when they're selling their properties. And so a lot of these covenants were intentional, and then they detailed in them that there's only certain races could purchase property in these particular areas. With regard to gentrification, this is a social cultural phenomena in which neighborhoods that have been historically underinvested become renovated, which leads to a rise in property values and taxes that often results in the displacement of the lower income individuals who live there, and because they can no longer afford to live there. This can lead to those housing instability issues that I talked about, and also lead to homelessness and overcrowding for people who want to stay in those communities. And finally, discriminatory lending practices. So these are mortgage lending data, high rates of loan denial, higher than average interest rates on mortgages, and low numbers of conventional mortgages. And so the data is pretty clear that it continually demonstrates discrimination towards African Americans and the communities of color by engaging in this type of work. And there we can get into a question in terms of credit ratings and how those disproportionately impact communities of color, because it's really difficult to establish credit worthiness and whether or not that is truly reflective of one's ability to pay. So whether due to overt racism or tools such as these definitely have an impact on one's ability to purchase housing. Next slide, please. So now that I've given you some background, I want to talk about some evidence-based approaches to impacting health and improving housing. The first thing we need to do is prevent structural racism. So those discriminatory policies that I talked about, those other structural barriers that have established the foundation that's resulted in these inequities that I've talked about, we have to address those. We have to eliminate those racist restrictive covenants in housing and property deeds. we now have the legal support behind it. And so it is a productive first step for us to begin to try to integrate that into health equity conversations, as well as those housing policy conversations, to raise awareness of these covenants and to work to try to get rid of those. It's also important to know that current housing approaches are still biased. Now they're a little more subtle in terms of their practices, but they're still there. So we have to remain diligent, and we have to really, especially, this is a place for advocacy, make sure we're working with our city and local governments to make sure those housing and those zoning decisions are equitable and they intend to do what they are supposed to. We need to utilize a health and health policies approach or health impact assessments, and engage with broad coalitions focused on social change. These are the tools that can integrate health and equity considerations into conversations, policy decision making, and as well as help non-traditional public health audiences and healthcare audiences understand this impact. So we would use these with property developers, city planners, lawmakers, and other community members, so that they can consider and prioritize the health impacts of their new housing policies and programs. We can also establish community land trusts. And what these do is they enable low and moderate income communities to build equity through home ownership. And so typically 1/3 of the community land trust board is made up of the community residents, which enables them to have an impact on how people participate, but it also leads to the decision makers process being put in the hands of the community, as well as more assets being placed in the community. With regard to increasing affordability and economic choice, we can develop private initiatives to expand affordable housing through subsidies that will allow tenants to rent in the private sector, and through the construction of new and affordable housing, so that we can do this with strategies like the low-income housing tax credit, federal rental assistance programs, and the like. We need to enact and enforce state and local building and housing codes or land use and zoning policies that promote fair and safe housing options. Continue federal oversight for the fairness in lending practices. Make sure that our banks and the loan institutions are engaged in the standards that they are supposed to, and we can improve private sector banking and lending procedures so that there is equal opportunities for credit. Improve landlord-tenant laws and tenant protections so that tenants are not easily evicted without cause. Increase partnerships with investments from the healthcare sector to address housing as a key social determinant of health. We're seeing that with, to name a few, organizations like Kaiser. A lot of healthcare organizations are understanding that in order for their subscribers and their members to be healthy, they have to move outside of just treating the patient when they come into the doctor's office. And if we can address some of these things that are surrounding them, that can have a greater impact on health as well as affect their bottom line. And we should also explore private initiatives with organizations such as Habitat for Humanity, Rebuilding Together, Meals on Wheels, community paramedicine programs, and energy efficient programs that all help individuals to be healthy and safe in their housing. I also just want to acknowledge that many have said improving the housing quality may adversely affect certain individuals because, for instance, landlords may have to increase their rents, or they may have to remove units from the market, or they may just fear, pushback or backlash from, their landlords for speaking up. And so I would just offer to you that residents should not have to be asked to choose safe and healthy over affordable housing. Next slide, please. With regard to improving housing quality, we can improve housing codes to protect and benefit health. Building codes often contain ambiguous language such as safe, indecent. These are varied and they're subject to interpretation, and so they're applied unevenly and they're often applied unequitably. So that is an area that we can improve. We can implement protective housing inspections at the local level and improve enforcement. Supporting smoke-free multi-unit housing. 1 in 4 Americans live in multi-unit housings where in the absence of smoke-free policies, they are exposed to secondhand smoke. Work with the government and private sector housing financing organizations to ensure that it's standard practice to detect and mitigate radon, lead, and other housing hazards before new residents occupy a property. That, as surprising as that may be, that is not universal across all states. Create financing streams that produce low or no interest loans to repair homes or rental units that have hazardous conditions. Here's another thing we can do is enforce workforce training and credentialing for housing and code inspectors, home maintenance professionals, and perhaps home visiting healthcare professionals, so nurses who come in to these homes, increase their training so that they can report hazardous conditions. And finally, improve the data collection so that we can better document housing conditions at the state, local, and national level. Next slide, please. And before I move to education, I just wanted to raise up this one example of a housing policy that, because I did not mean to suggest that all housing policies are negative. So in 1994, HUD created a demonstration project, basically which was called Moving to Opportunity, and it was a housing mobility program which aimed to improve social and economic outcomes. And essentially what they did was they divided it into 3 groups, and so they had some individuals received housing vouchers where they had to move to a neighborhood that had low poverty, vouchers where they did not have to move, and then a control group. These were provided to almost 5,000 low-income families and children living in public housing in some of the most disadvantaged neighborhoods. And so from this report, which was published in 2011 in the New England Journal of Medicine, the key findings were adults receiving housing vouchers had a lower prevalence of severe obesity and diabetes compared to controls, and reported fewer physical limitations and improved health in areas such as depression and psychological distress. And among youth, there were lower prevalences of psychological distress, mood disorders, panic attacks, oppositional defiant disorder, and fewer serious emotional behavioral difficulties among the females. You didn't see much of a difference in males, but there was also a reported differential impacts by gender for problem behavior. Next slide. So now let's talk about education. Education is a major determinant of health because a high school diploma, which is often used as a proxy in health research, is an indicator for a lot of things. High school graduation is a public health priority, noted one, and it's also a leading health indicator in our Healthy People 2020 Adolescent Health Objective 5. Next slide. So why is this? It's because we know that health and school success are 2 sides of the same coin. You cannot have one without the other. And it's intuitive, right? Because learning can't occur if a student who is not feeling well, either physically or emotionally, they're just not going to be able to produce in school and pay attention and be attentive. Next slide. In addition to this being intuitive, it's also supported by the data. So as we see here, there is a direct correlation between years of educational attainment and mortality. The fewer years of education, the greater likelihood of premature death. And the reasons for this are complex, including poverty, unemployment or underemployment, the lack of access to healthcare, less opportunities to learn, and those have an impact on whether or not you can begin to implement health promoting behaviors in your lifestyle if you have issues around education equity. We also know that having a high school diploma increases your livable wages, which increases your likelihood that you'll be able to purchase health care and also be employed with an employer that will provide health care. And if we look at the data, it also shows that by contrast, students who drop out of high school are more likely to die at younger ages as adults from chronic conditions such as heart disease, cancer, infection, lung disease, diabetes than their peers who graduated. Next slide, please. So as I talked about, many of these young people that drop out of school, they drop out of for many of the same reasons that place them at risk for poor health. And that would be homelessness, chronic stress, trauma. And here is a graph of a meta-analysis that was conducted by Charles Bash. And in his research, he identified 7 key educationally relevant health disparities that have their roots in disadvantage. So those include lack of physical activity, pregnancy, which is the most prevalent reason girls drop out of school, hunger from not eating breakfast, and also just hunger in general, unmanaged asthma, undetected vision problems, behavior issues related to hyperactivity and inattention, and exposure to and exhibiting aggressive or violent behavior. If anyone is interested in this work, this was published in the Journal of School Health in 2011. This next slide, please, shows the causal pathways to dropout and how each of these health disparities has a direct impact on either perception, cognition, school connectedness, or attendance. So yeah, I'm just going to talk through this chart with you all if you will just read along with me. So in each of these problems, there's a root influence that stems from a school circumstance, which is most often associated with a low socio-economic status or marginalization. And all of these issues impact neurocognitive functioning, which in turn influences disengagement from school and limited feelings of school connectedness. This goes on to influence attendance, the opportunities to teach students, the opportunity for them to perform effectively, and then we see the pathway to dropout. In addition to a variety of the adverse childhood experiences that can interfere with secure attachments between adults and children, we know that intimate attachments or attachments, if students do not receive the intimate attachments in school or from a caring adult in school or from parents, then that's going to lead to them seeking it out in risky behavior. So whether that be sexual activity, gang membership, self-medication with drugs and alcohol. And we're seeing this as early as elementary school, and we're seeing behaviors such as hyperactivity, aggression, and violence. Next slide, please. This slide just highlights how the disparity in graduation rates it's broken down by race. And I just want to be clear that this is on-time graduation. So we really do highlight that it's important to not only graduate from high school, but to graduate on time, which is in the 4 years. And as you can see, Black and Latinx students with disabilities, students that are low income or English language learners experience greater lags in graduation rates. Next slide, please. So where do we go from here? So this is the American Public Health Association's graphic depicting the chaos that often erupts in the school setting. So we call this a chaotic hallway. And basically this is what students are facing before they even walk in the classroom. This is what they're bringing to school. These are all those social determinants of health that we discussed. And what it hopefully highlights for you is that schools cannot and should not do this alone. We all have a role to play in addressing these social determinants. And a recent study by the community in schools noted that this impact of poverty is so great that teachers are often finding themselves helping students address these things before they can even get to the educational issues. So this study found about 91% are using their own money on supplies. 54% have used their own money to help feed students. 20% have are using their time to help students address problems outside of the classroom. And these are problems that we know that the health and healthcare sector can address and can be very valuable. And I'm going to tell you how. Next slide, please. So if you haven't heard, there are things called school-based health centers, and these are clinics or centers that are located on the campus or near or adjacent to the campus. And we have found they have been proven to be effective in delivering access to care in these marginalized and urban and rural communities. They can often be a touch point for those hard to reach populations, and they can identify those risks and intervene early. So we at APHA realize that they are poised to actually serve as a great conduit for how we can address the social determinants of health and help them achieve educational success, which is ideally, as I said, on-time graduation from high school. So what APHA does is we work with the education professionals to integrate public health strategies in schools and address the social and environmental conditions that are surrounding those marginalized students. I can't not tell you how many times I have had a conversation with educators and I say, how many times have you asked students, do they have running water? How many times have you asked if your students have electricity? I've even asked clinicians in the school-based health centers that question, and the light bulb seems to just pop on. So that's just one example, and I'm going to get into a little more practical as examples, but it is as simple as really just doing what we do best, and that's helping these other sectors understand how these various things work together and have an impact on health. It's important to note that school-based health centers currently operate really, as we know, at the secondary prevention level. So basically they're catching most of the youth that are coming into the centers, and they're catching them on a case-by-case basis. What we really try to do is work with the schools to expand this model school-wide, and so that you're addressing all students and that nobody's falling through the cracks. And in many cases, these school-based health centers and school administrators have embraced this issue, and they're now being more deliberate in their engagement with not only the students, but also the community at large and other stakeholders. Next slide, please. So for the past 5 years, APHA's Center for School Health and Education has provided technical assistance to and capacity building assistance to 14 schools and school-based health centers across the country. And basically what we're doing, these are our goals. We're seeking to increase attendance, decrease disciplinary actions, improve housing and food security, improve school climate overall, and of course, graduation. And we do this through clinical interventions, as we said, but our main emphasis is preventing them from going there in the first place, and really to change the policies and practices that are impacting health. I want to, if for more information, I want to refer you to our website at the bottom, which is schoolbasedhealthcare.org, as well as our Twitter. Follow us on Twitter at @StopDropout. Next slide, please. So here are some approaches to how we do this. So let me just give you an example. So Kim comes into school late. She arrives at school late. She's not in uniform, and she has a bad interaction with the school resource officer who is manning the metal detector that she must walk in before she goes to school every day. He tells her she can't come inside because she's not in compliance, and Kim's just not having a good day, so she decides she wants to walk in anyway, and he tries to enforce this by grabbing her. She yells, "Don't touch me." An altercation happens, and she ends up aggressively being restrained on the floor, and other students are watching. The principal comes, he sees all the commotion, and he takes her aside and he talks to her. And after talking to her, he learns that she's been couch searching for the last couple of weeks because they were evicted. She's hungry because she's not getting regular nutritious meals. She didn't wear a uniform because she was teased last week because the uniform smelled because she couldn't wash her clothes. So should we be suspending Kim from school? So that's a rhetorical question. But I would say to you, these are the types of things that APHA works on. And our approach would be, first, let's get rid of those school resource officers. We don't always need those school resource officers in the building, and especially not the first person that the students see when they come in. We talked to a lot of students who are walking past places where they're barking dogs. We talked to one student who walks every day past a place where she was sexually assaulted. And then they must walk into a place where they are walking their metal detectors with aggressive school resource officers. So you can imagine the impact of their ability to learn. We could also do things like addressing the emotional climate in the top right, where we could send her to a cool down room. So we have placed cool down rooms in schools where this is where they go to de-escalate. And then they come and they talk. So we deal with the social emotional learning, and then they go and they talk to the administrator about the issues. We've also worked with schools to create food and clothing pantries, also to destigmatize the hunger. So things like putting fresh fruits and vegetables, granola bars at the door so students can grab them as they walk in. We've also worked with schools to put washers and dryers and showers and house security guards by these so students can come in and wash their clothes and take showers. And we also work with schools to provide resources to families, so whether that be job training, where they can access more resources, where they can get skills development. And also, we've also worked to create peer juries in certain schools so that they have an opportunity to talk to their peers, and then the peers can determine the discipline. Because that's not to suggest that we shouldn't hold them accountable, but we often found that when you involve the community and they understand, and when they hear it coming from their students, there's more abilities to be accountable for their actions. Next slide, please. So that concludes my presentation, but I also want to leave you with, if you're interested in getting more involved in policy, advancing some of the issues we've discussed, APHA currently has an action alert where we're supporting some health equity legislation that we've endorsed. We're going to have some on police violence in a couple of weeks. So visit our website. This is our Take Action page. You simply type in your zip code and it will send you to your elected official, and you can either call or send an email for more information. And my last slide, please, just provides my contact information. Thanks again for the invitation to speak with you today, and feel free to contact me if you would like more information about APHA and our programming.
Dr. Davis-Moss, thank you very much. That was a very powerful intervention that you made. You just provided for us the story of Kim and others, the story of hundreds of thousands of young women and young men and older women and older men, children and adults alike, who are really enduring and suffering from conditions that are not of their doing, but which we can do a lot about. And you gave us a wonderful description of two aspects of those social determinants of health that we were addressing, that network of inputs that affect all of us, regardless of our racial background, that are vitally important for determining our future as individual human beings. So what I'm going to do is just address a couple of other issues that feed into what Dr. Davis-Moss had spoken about. I'm going to talk about healthcare and talk about the environment, and then we're going to go and have maybe a couple of questions I'll ask to Dr. Davis-Moss, and then we're going to go to your questions. So please give us your questions, send them in on the box that you have on your computer, and we'll get to as many of them as possible. So I want to talk a little bit about healthcare, obviously, and Dr. Davis-Moss gave a wonderful description of the interplay between education and health. But in our country, in the United States today, should I say, if you look at why people are dying, apart from infectious diseases, it's actually non-communicable diseases, the heart disease, the cancer, the pulmonary disorders, diabetes, and mental health that are causing the greatest amount of death and disability in this country and in fact around the world. Non-communicable diseases, that bucket of diseases, are responsible for 70% of deaths worldwide and the primary cause of disability here in the United States too. The interesting thing is we can prevent a lot of those problems. Investing in public health is the cornerstone to being able to do that. But can individuals of color, can African Americans and Latinx and First Nations individuals, can they access that? No, they can't. There are deep racial imbalances, a lack of access to public health, to primary care that we have in the United States. Those are political decisions. Those are choices that are made. Therefore, they are decisions and choices that can be reversed. And because the communities that we're talking about here have the worst outcomes, as we are seeing through the COVID-19 outbreak, it behooves all of us to double down and provide extra investments into those social determinants of health that are going to have the impact and output that all of us want to redress those historical injustices. So how could we do that? Well, let me give you an example. So both Dr. Davis Moss and I are actually here in Washington, D.C. I think you will be shocked to know that in the capital city of the United States, if a woman is in labor and she wants to deliver, there are parts of the city that a woman has to travel over an hour to get to a hospital that she can deliver her baby. And those communities are African American communities. That I think a lot of people are not aware of. Let me give you another example. In St. Louis, there's a street called Del Mar, the Del Mar Divide. It's a street that cuts across St. Louis. North of that city, it's almost exclusively African American, much lower income, but between lower 30,000, upper 20,000 per year, and much higher crime rates. Below that line are much higher income, much higher housing values, as Dr. Davis Moss mentioned, and much better health outcomes. What happened above the Del Mar Divide, above that line in St. Louis, is that the health clinics were actually shut down in those communities north of that divide, which meant that African American communities primarily were being deprived of access to essential health care. That was a choice and a decision, which only exacerbates the outcomes that Dr. Davis Moss and I are talking about today. Those are choices, those are decisions that do not have to be made. And that's happening around the country. The other area, of course, is investments in public health. And sadly, despite the fact that investing in public health is your best bet to be able to improve health outcomes, public health is chronically not only underinvested, but we're seeing cuts. Remarkably, we're seeing cuts in public health across the United States. It is illogical by any stretch of the imagination that should happen. So there ought to be an increase in access to public health, and that includes an important area that we can talk about a little bit later, is the issue of nutrition. Dr. Davis Moss, in that really powerful description she had of kids going to school, there's one child bent over holding their stomach because a lot of kids who are poor don't get access to proper nutrition. They don't even have access to breakfasts. That's why those teachers, 51%, are actually paying for kids to eat, because you cannot study, you cannot learn on an empty belly. So it takes very little to invest in access to proper nutrition, which pays off remarkably in enabling those kids to be able to study, to learn what any of us want children to be able to do. Finally, I want to just talk a little bit about the issue of the environment before we get into some questions. In the United States, there are areas where polluting industries are actively put into areas where African Americans, Latinx, and other communities are living. And the impact is significant and deadly. There's an area, and I encourage you to look at it, called Cancer Alley. Cancer Alley is located in Louisiana. Along that alley are primarily African American and Hispanic communities. It's where a lot of industries are put. These industries are churning out cancer-causing agents into the environment. It has a profound and negative effect on the lives of these people. So if you look across the country, unbelievably, polluting industries have been put into communities of color, low-income communities, poor communities, African American communities. That's where these industries have been put, and the outcomes are deadly with much higher rates of cancer. Farm workers are another group where they're exposed to all manner of toxic pollutants, and many of those folks obviously don't have access to health care and to services. Finally, I just draw your attention again to something I think most of us know about, which is in Flint, Michigan. Flint, Michigan had the lead water crisis. Remarkably, lead in water has a lead access, particularly for children, is a powerful negative, disastrous effect. It's a neurotoxin for children. But there were pipes, and in Flint, the water was polluted by lead. Remarkably, even today, years after this is known, Flint still does not have the investments in water access that they need to have. So we can see that in terms of race-based access to environmental issues, there's a push-pull issue. There's an increase in hazards that we've just been speaking about. There's also a lack of access to environmental solutions, so access to green space. Green space is access to green space is a powerful and important asset, natural asset, to improve and reduce non-communicable diseases, including mental health. And African American communities do not have access to the same level of green space and other environmental ecosystem services that others do. So I just wanted to briefly talk to you a little bit about that. And finally, on the issue of judicial reform, here at CUGH, we provided access to, and we had a webinar on reducing gun violence in the Americas. We feature the Chicago Crime Lab. And I encourage you to take a look at the work that's been done by the Chicago Crime Lab. So despite the high level of homicide rates, on a shoestring of investment, the Chicago Crime Lab, working with community partners, have actually identified the individuals who have the highest risk of not only committing homicide, but also being killed through murder. And we can do this through data. We can identify what who those individuals are. And you know what you need to do to be able to dramatically reduce their chances of being killed or killing? It's to be able to do what Dr. Davis Moss mentioned: access to education, access to jobs, access to housing. These are critically important, low-cost interventions that can dramatically change the arc of a person's life, the arc of their family, and the arc of their society and their community in a very positive way. So my point is, the solutions exist. You've heard them from Dr. Davis Moss. We know what to do. It's just a question now of whether we're willing to do that. And given the COVID-19 pandemic we have today, given the light that's been shone on the growth inequalities and disparities and outcomes, and the disproportionate death and disability affecting African Americans, Latinx, First Nations communities here in the United States, it behooves us, all of us, to be able to take those solutions, those evidence-based solutions we know that work, and fight for them to make sure they're politically implemented. So I'm going to stop there and just ask Dr. Davis Moss a question, if I may, and then we'll get to your questions. So I encourage you, please, to send your questions in. Dr. Davis Moss, if I could ask you a question, do you think that poor communities can often have poor schools? So they're caught in a Gordian knot, a knot of a sorts that's hard to disentangle. But do you not think that federal equalization payments are absolutely necessary to make those investments that poor communities can have through their tax base? Is that a way that we can get resources in to strategically invest in schools and schools that are already in poor areas that can never on their own access the resources needed to be able to strengthen their education system?
So I would certainly say I'm not as familiar with the context of equalization payments, but if in equalization payments include investing at the extent that the resources in providing the resources to the extent of the need, meaning it's not just applied equally, it's applied to those that need it most, then yes, I do think that has an impact. So I mean, let's go back to Brown versus Board of Education. That was to desegregate, right? But there still remains, the schools still remain segregated. I mean, there's still discrimination in schools by administrators, teachers, students. There's racial bias in the school curriculum. There's separation of students into different abilities based on their race, class, and their gender, standardized testing, and just, as you said, just invest in general, the resources, the books, all of those things have an impact on the ability for the schools to perform well. So I don't want to suggest that all schools in low income communities do not perform, because you do have some really great examples, but in those schools you often find administrators and teachers who are very committed, are intentional, deliberate, usually using their own funds, and usually working a lot more hours than they're called to do to make sure that those 6 students succeed. So basically they are personally committed, and it's a life mission for them.
Yeah, no, thanks very much, Dr. Davis-Moss. And indeed, school teachers are doing it despite the fact that, in my personal view, they're grossly underpaid for the work that they're doing. And as you mentioned, 91% of them are providing school supplies, paying for school supplies out of their pocket, and 51% are purchasing food for kids so they can at least eat, which is a remarkable testament in and of itself. So that leads to a question from Larry. And Larry wants to know whether the education department is actually, in the face of COVID-19, are they increasing investment in public schools right now?
Well, that's that is a great question. I mean, we hear our current administration threatening to remove some investments if schools do not open. So, that remains to be seen. The investments are often tied to certain benchmarks, as we say. So there are certain things that you have to do to get those investments. And, there are public schools versus charter schools versus independent schools. So I would say there's not a straightforward answer in that. And I would say, yes, there are increases in investments in schools, but the distribution is very variable, and it's often tied to things that the school may not be able to realize those investments because they haven't met those benchmarks.
Fantastic. And this question comes from Andre, and Andre wants to know the importance of access to universal health coverage for low-income communities. And
yes, I mean, universal coverage is great. It's a first step. I believe health is a human right, but we also have to be mindful, and I hate to be the but in everything, but we have to be mindful that the notion of utilization of care. So I always say, just because you provide it, or just because you build a clinic, doesn't mean that they come, okay? Because there's got to be respectful care. It's got to be care that's not dismissive. It's got to be accountable, culturally sensitive. So there are a lot of things that also come into play when we're talking about providing the care. But yes, that would be a great start if universal care was just at the floor of this.
And I think one aspect is certainly providing, personally, Medicaid for all as an option. If people want to get access to Medicaid, they should have access to Medicaid, because the United States, being the only developed country in the world that does not provide public health or health coverage for its citizens, stands as an outlier. And as a result, we see this country spending the most on healthcare and having the worst outcomes of any developed country, which is tragic for all concerned.
Absolutely.
And so I think, one question from Carl would like to know about, as you mentioned, Dr. Davis-Moss, about the issue of, it's an opportunity, structural racism within healthcare, and you alluded to some of this. What other things could we be doing in the healthcare profession to reduce structural racism in the United States?
So sure, I mean, we've heard the term implicit bias training being thrown around a lot, right? And so that's essentially where not just the doctors, but the medical staff, if they're in a health department, it would be the health department employees, a large group of individuals that have some stake in providing care to the patients receive this training that helps them become more aware of any of these prejudices or these unconscious prejudices that exist, or these patterns of thinking that have an impact on how you believe a person will behave, or a group of individuals will behave, or their beliefs. And so there's thoughts that by engaging in things like implicit bias training, that will counteract, what we now learn, that a lot of doctors, when they go through medical school, or clinicians or nurses, do not receive a lot of that training. In fact, sometimes the medical curriculum enforces some of these notions around there's differences in pain tolerance, a lot of things, so let me answer the question before I make my point. Okay, so I do think things like that are important, but I do not think they're one-offs. I think this is a ongoing process that you have to have a part of many things to do in terms of addressing these kind of issues. So in addition to the training, you also need accountability boards. We're seeing a lot of that work with regard to maternal mortality. So what happens when the things happen, what happens, and then on those boards, you have individuals from the community that can participate, and as well as almost kind of like a Yelp, or I know we have these sort of things already online, where people can actually go on and understand and read about the different experiences in different places. Back to my initial point about the curriculum, I want to be very clear that there is no race gene per se that makes people, for instance, Black people, more susceptible to these certain things. There is the inequities that create the problem, and it's the disparities. They die due to the disparities. So, it's racism, not the race, that is driving the issues.
No, that's very, very well said, Dr. Davis-Moss. Racism, not the race, that's causing these issues, and disparities are killing people. So one final question before we wrap up, and it relates to graduation rates for African Americans and other minorities, particularly in this COVID-19 environment. How can high school graduation rates are extremely important, as you mentioned. What can be done to increase access to post-secondary education and the completion of post-secondary education in the United States?
So right, as I said, so we do focus on on-time graduation, but we recognize that that's not always a course for a lot of people, and so that is the point would be, if it's not within 4 years, we just want you to get the degree. So there's some great programs. There's one in DC, name escapes me, but the executive director is, her name is Leicester, and she is a model program for, I think it's Academy of Hope. So this would be a great program for adult learning, so that individuals can go on to obtain that GED or that high school equivalency. And there's also vocational and job training, basically schools that teach these sort of things within the high school curriculum, so that kids come out having a skill, because as I would say, the high school diploma is just the ceiling, right? I mean, ideally we want more education because that increases the ability to earn a livable wage, but minimally we want the high school education. And so as I said before, there's several model programs, how you can do that outside of the traditional model, that I'm happy to, if that individual wants to email me, provide him with resources.
Okay. Thank you very much, Dr. Davis-Moss. And I'll just close by, before I have a closing remark, is there anything else that you'd like, any other final messages that you'd like to give to our audience today?
Again, thanks for the opportunity to present. I like many, are dealing with all of the changes that are happening in the world and faced with the reckoning that we all have come to understand. And I hope that you all, like many of us, are in wanting to be engaged in things that are going to actually move the needle in terms of health outcomes. And so we invite you to join us in this work. APHA is engaged in a huge initiative entitled Advancing Racial Equity. We have a multi-part webinar series where we're doing deep dives in some of these issues. If you just want a primer on how this operates, you can log onto our website. We just did one on racism and health. Most recent one was on reproductive health and racism, and now we're going to be focusing on policing. We're also going to be looking at policies that we know work, as well as environmental racism, amongst some other things. So please join APHA in this fight to improve the health of the public and achieve equity in health status.
Thank you very much, Dr. Davis-Moss, and we'll certainly share the APHA's webinars with our network at CUGH. And I would encourage all of you to take a look at CUGH has a new program that we started. This is an election year in the United States. It's called Global Health Votes. So it is to achieve, as Dr. Davis-Moss mentioned, we all have to roll up our sleeves and get involved to move the needle forward and elect those individuals who are going to address the very issues that we spoke about today, the issues that are affecting people by race, that is killing them through the disparities that exist. And before I leave, I'd like to just leave a quote to you from Representative John Lewis, a giant of the civil rights movement who passed away recently, an extraordinary man, to say the least. And in his final words, he said this: "Though I may not be with you here today, I urge you to answer the highest calling of your heart and stand up for what you truly believe." Thank you for joining us today on this webinar, and we look forward to seeing you soon.